Good morning. Good morning, everybody. Uh, talking from Kerala. This is one of the provinces in South India, and about the challenges that we face in our community-based home care program in palliative care, while we look after patients with neurological problems. And before I start with my actual presentation, I'll give you a background because that's the way it may make sense about what's happening in Kerala. Can I have the next slide, please? Yes, okay. And so let me tell you about palliative care in Kerala. Some of you may be aware of it, some of you may not. Kerala has a very broad community-based palliative care system, and the major players are one local government. This is what we call panchayats, village level government, and also non-governmental organization. Private hospitals play only a minimal role, so but the other two play a major role. And there is very active participation of community volunteers in hands-on patient care. I'll explain it again. So we have, it's a population of around 34 million, and we have around 2,000 palliative care home care units covering this population. And as I mentioned, the one major player is the local government, village level government. So out of this 2,000 units are run by the local government, and another 600 units by non-governmental organization. Something very interesting about Kerala is that there are around 400 palliative care home care units run by different political parties directly. That is something unique. And this is what's happening. Like we have specialist centers, district level centers, and also state level major training institution, which look after a small percentage of patients, those who get referred from the ground level. These are patients with complicated problems who need specialist palliative care attention. Most of the care, around 90% of the patients, or maybe more than that, they are looked after at the primary healthcare level by the primary healthcare team, with a huge input from the trained informal carer in the community. So what's being delivered? What's being delivered? Because when I just say palliative care, now I'm going into details of what is being delivered. The community volunteer support, the trained volunteers are given structured training, and they are involved in mobilizing and offering social support, companionship, some amount of emotional support. They sit with the patient and family. Then this is followed up by the home care team. Their trained nurses are the lead in the home care teams. The frequency of visit usually depends on the condition of the patient. They talk with the family, sit with the family, train the family in basic care of the patient. They address wound care, and they also train the family in wound care and change of catheter, change of nasogastric tube, and care of nasogastric tube. These are some of the basic issues they look after. And there is some basic physiotherapy support by the physiotherapists in the team. They train the family member. They are not available to do direct physiotherapy to all the patients, but they assess the patient and train the family member. And there are certain patients who need lymphedema care or ostomy care. They are being taken care of by special care units. And the whole thing is supervised by the local doctor, either the doctor in the government primary healthcare sector, or a doctor in the palliative care unit run by the non-governmental organization. So outpatient clinics are also, there are dedicated outpatient clinics for these patients also. And then medicines are provided by the primary healthcare centers or the palliative care unit. The whole package is free. Patient does not pay. This is maintained both by the local government support and also by donations from the community. This is what's happening. And the target population, the type of patient that we look after, one is definitely patients with advanced cancer. Then patients with stroke. After the acute care, they get discharged from the hospital and they also get enrolled. And there are also other neurological issues like accidents, irreversible head injury, spinal injury. Quite a large number of people fall from height, either climbing up the coconut tree or from construction sites. So they also are catered to. And then there is chronic progressive neurological and neuromuscular disorders, and old age with multiple diseases, end of life care, and end stage systemic diseases, cardiac, respiratory, and renal. There is AIDS is not a major problem, but we have a small number of patients with HIV and AIDS, and also particularly the developmental issues in children, mental and physical incapacitation. These are the basic target population. And when you look at the neurology patient, uh, 25 to 30% of our patient load is patients with neurological problem. One is stroke, as I mentioned, a stroke patient after acute care gets discharged from the hospital and is at home and they register. Spine injuries, again, after the acute care, they get discharged from the hospital and they register for palliative care. Then late stage Parkinsonism, other progressive, mainly Parkinsonism, but there are also some other progressive neurological conditions. Then there are progressive neuromuscular conditions, particularly in children. These form the neurology, what we call the broadly called the neurology patients in the community. And then the problems that we see. One is a problem with mobility, activities of daily living, bladder care, and also practically there are very few rehabilitation units available and lack of access to physiotherapy. This results in worsening stiffness and progressive problems with mobility. Then most of the patients have, except those with spinal cord injury, the other patients have cognitive impairment, inability to communicate and getting into conversation. And other pain, multiple musculoskeletal, neuropathic, and other pain syndromes are common. Falls, we found that falls or accidents are more common for these patients because they are not able to move around comfortably. Malnutrition and dehydration is an issue. Pressure sores are major issues. Then many of these patients undergo are in depression, anxiety, or emotionalism. Sexual dysfunction is very common. And above all, financial problems are very common, and spiritual issues are also there. These are the problems that we see the community palliative care team see when they see the patient at home. And the carers also have a major problem because carers they're stressed and they handle the major care burden. And something that we notice that they have most of the carers do not have a good understanding of the role that they have to play, and also they are not trained at all, or some of them have basic training, but most of them are not trained at all. And then among the carers, there is very high level of emotional strain and distress. Negative emotions, adjustment disorders, anxiety, and depression are very common among carers. And then there is a lack of support. Most carers, when we talk to them, they feel that they don't get enough support and that the quality of life is significantly reduced. Financial problems because family undergo a crisis and they have financial problems. So what are the key challenges? These are the issues that we face, and these are the issues we are trying to address. And now, what are the key challenges that when you look at from the neurology aspect and that perspective, the community palliative care aspect, what are the challenges that we face? First challenge is again the way deciding when to start intervening, because the line between palliative care and rehabilitation is very blurred. So when do you start? Actually, this is a theoretical question. I'll come to that later. And so lack of clarity on the role of rehabilitation service and palliative care services in the case of individual patient. But as I mentioned, this is mostly theoretical because practically very little rehabilitation service are available. So whatever service available is the services provided by the community palliative care team. But this question is there. When do you start? Where do you draw the line? When do you say that, okay, now this is time for the palliative care unit to take over? So that is an issue. And the second challenge is the lack of communication or lack of contacts with the neurological unit. Specialist neurological services are all in the institution. They're institution based, and they act more or less like watertight compartments with no interaction with the community based system. So that is a major issue, which again, when you look at the care that is provided by the institution, when the patient is admitted or when the patient have access to that, particularly in the initial period, you find that there is no emotion. There are a lot of problems are emotional, social, and spiritual also. So you find that they are not addressed by specialist neurology units, and there is no attempt there. And there is absolutely no system of back and forth referral. The patient gets discharged from the hospital, they are not referred for supportive services, and the community services are also not able to refer the patient back to. So there is a very sort of practically very little communication between the specialist neurologist units and the palliative care unit in the community. And the third one actually is to again to deal with the competency of the community-based palliative care teams. Like how competent are the community-based palliative care teams, the volunteers, the community nurses, and the primary healthcare doctors? How competent are they to look after these patients? How competent are they to take charge? So we have found that the most of the training that they get is basically on basic palliative care, and that's enough for most of the patients. But again, when complex neurological issues come up, the team is not competent enough to handle. So that's also an issue. So what would be the way forward? How do you address we have been talking about this for quite some time. We have been talking to neurology, but there is no way other than better networking between specialist neurology units and community-based palliative care. The community-based palliative care units in Kerala, we have the manpower. People are willing to help, people are willing to intervene, but they need to be made more competent, and they need to network with the specialist palliative care units. And the neurologists, I think the interested neurology people who are willing to do this will need to address some of these information needs, some of the training needs and guidance. And definitely there's a role for some continuum of care. When the patient gets discharged from the hospital, from the specialist neurology center, they need to be referred to the community center, and from the community center, if they have a problem, we should be able to refer them back to the specialist hospital. This is the basic idea about this will mean specialist neurologists, specialist neurology units in Kerala taking interest in what's happening to the patient in the community, taking interest in the system that is available to look after the patient, taking interest in looking at the gaps, and also trying to fill the gaps. And thank you very much. And this is my email address, and I'll be happy to take questions after the session, definitely, and also later on, if you feel free to write to me as and when required. Thank you once again.